This is a lecture on Neoplasia II from Pathology. And we will be covering a lot of different things, but to start off with, metastasis. This concept of metastasis is basically that we have a tumor in one little area, and here's that little tumor in situ or in the tissues, and then a little piece of it will break through this border, and it will go out into maybe the lymph system, or it will go into surrounding tissues of the blood, and maybe it'll go from the lymph into the blood like this, and then it will end up getting stuck somewhere like this, maybe in the lungs, and then it'll start to grow and get out of control. And that's the concept of metastasis. So tumor implants are not continuous with the primary tumor. That's basically what it is. So here's the original tumor, and this implant is not in the same location as the original over here. And we understand that benign tumors don't metastasize. So here's a benign tumor because it hasn't metastasized yet. But once it starts doing this here, then we call it a metastatic tumor. But there are some exceptions. There are some malignant tumors that do not metastasize but are still invasive and malignant. An example of that is a glioma. So a glioma, shown here, this happens in the, I believe the glial cells in the central nervous system. These are invasive. They don't metastasize, but it's still malignant. Also, basal cell carcinoma. This is another one that doesn't tend to metastasize, but it is still malignant. 30% of tumors have already metastasized before they are even diagnosed. So before you even diagnose a tumor, it's already gotten to like this stage here somewhere. The next concept here is the seeding of body cavities and surfaces. So in the case of a malignant tumor, what it does is it penetrates the surrounding area. And this usually involves the peritoneal cavity. And he starred this multiple times. Peritoneal cavity is the main time that this will happen. But it could also include other areas as well. It could be here. Another example is the ovarian carcinoma, as I showed down here. This would be one that tends to, seed in other body surfaces or cavities. So the next thing is understanding lymphatic spread. So when a person has a tumor, let's say a woman starts to develop, or a man starts to develop a tumor in the breast area, as shown here, what we do with a sentinel node biopsy is we inject this tumor with radioactive dye of some kind. Sometimes it's just color, sometimes it's just the radioactive part, sometimes it's both. And then what will happen is this dye, where's it going to go? Well, it's going to drain. It's going to drain to its nearest sentinel nodes. The nearest sentinel nodes are the first ones that it drain to. So what we do is we cut out the cell region, and we cut out those nodes. So I cut out both of these things, and then we biopsy them. And we're going to look at them, and we're going to see if these nodes are, if they contain these original tumor cells, and if they do, that would be indication that this tumor has metastasized. And so it says the conditional sentinel node is reflective of the remaining nodes. So how these nodes are doing, if these don't have anything in them, then probably none of these other ones do either. But if these ones have it in it, likelihood is that these other ones might as well. So the metastatic carcinoma in lymph node, as the image over to the right, what it does is it tends to enter the lymph node through the subcapsular space. So when you have a lymph node, you have this kind of capsule going all the way around it like this. And these cancers tend to enter into this area, and this is where they'll tend to reside and start to grow out of control. So when you look for a tumor, it's going to be, see this whole subcapsular space here, just inside the capsule? That's where this tumor has gone. All those cells are looking pretty bad in there. This is where the tumor is up in here, the subcapsular space. Here is an example of the subcapsular space here. It's that space right in there underneath the capsule. Here's the fat, and here's the lymph node, and here's the subcapsular space. He said that was really important. We also need to understand the immunohistochemical stain of keratin. So whenever we're looking at an epithelial cell or maybe a cell that has come from breast tissue, it's going to be easily markable with some different things. So when looking at breast cancer or any epithelial tumor, ERPR can be done. What's ERPR? It is estrogen receptor antibodies and progesterone receptor antibodies. ERPR from the breast. So this special kind of stain will point out and these particular cells, and you'll be able to identify that based on that type of stain. And that will say if it has those, ERPR must be from the breast. Next, you can also check the CK, which is the cytokeratin, or cell keratin, because if it's an epithelial tumor, it's going to stain with this. It's going to have this keratin staining in it, and it will always appear dark brown in an immunohistochemical stain, just like the image below. Next here is breast cancer metastasis. So we talked a little bit already about the sentinel lymph nodes. Assessment of nodal involvement is very inaccurate, apparently, with both false positive and false negative findings. So when we do that nodal test that we talked about earlier, the sentinel nodes, sometimes it'll give you a false positive, sometimes it'll give you a false negative. It's just a difficult thing to tell. Nodal enlargement near cancer does not always mean dissemination of the primary lesion. So if you're looking at someone, let's say here's a breast here, and then this node is like really swollen over here, that doesn't necessarily mean that this has occurred, that the little cells have gone out here. It can mean that, but it doesn't necessarily mean that. So what sometimes happens, though, is that there's also a subdermal lymph node system, as shown here. This would be like a little bit of lymph up here in the subdermal. So here's this dermis, right? Just underneath the dermis and the subdermis, here's this area. Sometimes what will happen is these little cells, these cancer cells, will undergo lymphovascular invasion, and they'll come up here and they'll get in this area, and it'll make the skin above look strange. All these little dimples and things in it because it's got all these invasion into the subdermal lymph. And the condition for this they call peau d'orange. I don't know, it's French, I guess, which is the spread to dermal lymphatics. I guess that this look that you see there is similar to the look of an orange, and that's why it's French for I guess something about the peel of the orange or something. Next, we have usually the lungs and the liver are going to be the first place for the hematogenous spread. So hema, you usually think of blood, so the blood generating spread. So when it goes from the lymph into the blood, where is the first place it's going to go? Usually it's going to be either the lungs or the liver. The pathologists, though, usually feel like they can figure it out. They can say, okay, if a person has some tumors growing in their liver, well, then that must have been an instance where it drained. If you remember, here's the liver like this, and here's all the intestines in here, right? And it all drains up through the portal vein. Well, where's the first place it's likely to get stuck? If you have cancer down here, the liver. So they feel like you can say colon cancer usually goes to the liver, whereas renal cell carcinomas usually invade the branch of the renal vein. That's straightforward. Hepatocellular carcinoma often penetrates the portal and hepatic radicals. Liver shown below. So here's that liver that I was talking about here, and you can see those tumors growing in it. Here's an example of the lung. Here's another liver histological stain here. Next is chronic inflammation and cancer. When something gets inflamed for a long, long time, it causes a lot of irritation, and the cells start to behave differently, and it causes a lot of divisions, which really increases the likelihood for dysplasia to occur. And in the instance of this kind of dysplasia and massive proliferation of cells, cancers start to form a lot sometimes, increases likelihood. And there are some things that can cause this constant inflammation. And one of the things here is something called Barrett's esophagus, and this is shown over here. So what happens in Barrett's esophagus is, so here's a guy, right, and here's his throat, And then going down here, then we have his stomach, right? So typically, the stomach acid stays down here. Sometimes people have this problem where the stomach acid will squirt up into here, up into their throat. And if it squirts up into here, it's going to affect these cells along here. So the cells that you have down in your stomach are these columnar cells that secrete mucus, and this mucus protects your cells from acid. And that's good because there's lots of stomach acid in here. So these columnar cells, what you find down here. But if you go up into this above this area, what you're going to find is a different kind of cell. You're going to find squamous cells. And these squamous cells, they're tough and they're good at handling abrasions, but they're not good at handling stomach acid. And so when stomach acid starts to squirt up into this region up here, they undergo some change in their cell types. They'll go from being squamous cells like you see here, and they'll start turning into columnar cells. And apparently when cells start changing like this into different types, they're like more volatile, and more volatile cells are more susceptible to cancers. And so it's likely that you'll get cancer from this, or possibility. Another instance, and I guess what you give these people are like proton pump inhibitors and things like that. Stop the stomach acid, calm down the stomach acid so it doesn't keep going up here and giving them Barrett's esophagus. Another thing that can happen with this is an infection with Helicobacter pylori, which can cause gastric ulcers and things like that. So here's Helicobacter pylori, nasty little booger. It goes down in here, and it's going to reside on the cell, and it's going to cause all these problems. It's going to ferment, I guess, to the side of the wall. And here's a picture of the Helicobacter pylori. And this inflammation will cause, gastric ulcers, but also can really increase your likelihood of getting cancer as well because of the chronic inflammation that comes as a result of it. There are other things too. For example, we have cervical dysplasia, and other infections can cause cancer as well. So HPV, human papilloma virus, genital warts, or just warts in general, they have this propensity. It's a virus, human papilloma virus, and so virus means it goes into the cell and it changes the normal function of the cell. Well, if you're and it causes overgrowth. All these changes increase the tendency for the cells to become cancerous. So here's normally what a cervix would look like over here, normal cervix. But I guess if you get HPV in there, it can alter the cells. They can start to change, and they have these ways of measuring this. They call it CIN, which stands for cervical intraepithelial neoplasia. This is normal here, and a first degree is going to be 1/3 of it. So here's about 1/3. If you break this thing up into thirds, there's 1/3 down at the bottom. This part is neoplastic. This guy now is 2/3 of the way neoplastic, so that'd be a second degree. And then a third degree, as shown here, would be the whole thing. The whole thing is messed up. That's one thing that happened. The other one is infectious, or just understanding infectious agents account for 15% of all cancers. So make a note of that. Okay, so now we got these liver flukes. So if you ever eat some raw fish from fresh water, you can get these nasty things that grow, little flukes can grow in your liver, and they can give you cancer. They can give you cholangiocarcinoma. And these liver flukes are called opisthorsis veraci or something like that. Can't remember. So that's a bad deal. Here it is down here. Can give you cancer. Again here, the infections, Helicobacter can give you cancer. Okay, so cancer incidence. All right, there are some geographic, environmental, or other things, genetic predispositions or non-hereditary predisposing conditions that can cause people to have a higher likelihood of getting cancer. Some of the really obvious ones is alcohol, increases the likelihood of liver and all kinds of other cancer, and smoking, which is really increases the likelihood of lung cancer and a bunch of other kinds of cancer. So human papilloma virus is another environmental issue. Smoking, alcohol, again, diet. Diet is something that eating certain foods can increase your likelihood of different kinds of cancer. Apparently, eating lots of red meat and high-fat foods increases your likelihood of prostate cancer, whereas a really high-fat diet, or I guess being high-fat, increases the likelihood of breast cancer. And obesity in general has a 14% likelihood of cancer deaths in men and 20% in women. So if you're fat, you're increasing your likelihood by 14%. Or maybe that's responsible for 14% of the deaths. Yeah, I think that's what it is. So environmental carcinogens include ones in the workplace, or maybe certain foods you eat, or it could be UV light. It also could be something like vinyl chloride, which can cause sarcoma of the liver. I don't remember what vinyl chloride is, but apparently it's something that had been around for a while. Maybe it was some sort of vinyl, looks like plastic. And then, of course, there's also asbestos, which is a popular one. So there's also such a thing as a genetic predisposition of cancer. So in the case where somebody has a genetic predisposition of cancer, this means that, it doesn't mean they automatically will get cancer, but that they're predisposed to it, where just a little bit of inflammation, or maybe some, might cause some proliferating cells, or something like this, might increase their likelihood of getting cancer. Not that they have inherited cancer per se, but just because of maybe they're higher likelihood of getting GERD, or some other chronic inflammation, it predisposes them to cancer. There's also non-hereditary predisposing conditions as well. So in the inherited predisposition to cancer, there's a few here that he touched on as being the most important, but we understand first of all that less than 10% of cancer patients have inherited mutations for cancer. There are three types of inherited predispositions to cancer. One of them is the autosomal dominant inheritance of retinoblastoma. So down here I have this kid. This is what happens when you take the pictures. Very sad. This kid has a tumor in his retina. There's also defective DNA repair. And defective DNA repair is, if I understand it correctly, I know it's a P53 is associated with Lee-Fermeni syndrome. I copied and pasted this from online. It says, it shows here the DNA damage, cell cycle abnormalities, or hypoxia, any of these sort of things that can occur in a cell. Apparently what happens is you have this gene, P53, that gets activated. And P53 can do a couple different things. If it sees, we have some damage here, then it can go in and it can arrest the cell cycle. If the cell cycle stopped, then the thing isn't going to be able to continue to mass produce and make a giant tumor. Or it can also undergo some DNA repair, go in there and activate things that'll fix it, and then it can start the cell cycle again, and then it can go to cellular genetic stability. But if it can't do this successfully, the other thing it might do is just go in there and initiate apoptosis. Apoptosis is programmed cell death. So it's going to kill this cell so it can't reproduce and kill you. Death and elimination of the dead cells. But occasionally somebody will have a defective P53 gene. And if that happens, then this whole process here can't go on. This happens all the time in your body. And if you can't do this, then your likelihood of getting cancer is a lot higher. And they call this Lee-Fermeni syndrome. And this is a picture offline of a kid who has this disease, and so has a cancer at a very young age. BRCA mutations and breast and ovarian cancer is another association we need to make. BRCA1 and 2 mutations are associated with this tumor suppressor. Actually, one place it seemed like it said tumor suppressor, the other place it said DNA repair. So that's something we need to look up and double check on. But here's a picture of a radiographic image of breast tumor. And here is an image showing ovarian cancer. And here it is on the chromosome 17, the BRCA1 gene. So now talking about carcinogenesis and tumor suppression. So here, all these white cells represent normal cells. Now, if one of these cells becomes mutated, it's going to start to divide out of control. And one of those sometimes will become mutated, and that one will divide out of control. And then one of those ones will become further mutated. And after a while, you get this really, really nasty mutation of cancer that's going to occur. And this is essentially the idea. If you think about it, if you realize it, all of these cells are in essence clones of this original cell right here. So this is kind of this clonal expansion that's occurred. And all these cells are going to have this one type. So if you look at a tumor and you're like, wow, every single cell has this certain kind of marker in it of the, one kind of cell, then that would be an indication of a tumor. So I guess there's also the emergence of subclones of a tumor. I believe that's what this is. These are all subclones. And the tumors are monoclonal, all come from a single cell, pointed on that. So there's 4 classes of normal regulatory genes. So to kind of handle with this whole process of carcinogenesis, our body has different ways of taking care of it. One is there are growth-promoting proto-oncogenes. So, you also have growth-inhibiting tumor suppressor genes. So these are genes that are going to inhibit the growth. You also have regulators of programmed cell death. So things that are going to say, all right, time for the cell to die. There's also DNA repair genes. And if any one of these things gets taken out, your likelihood of undergoing this whole process becomes worse. So this original mutation here, normally our body says, zap it, kill it, make it undergo apoptosis or repair the DNA for it, or inhibit its growth. But when any of these factors here go out, let's say, for example, the growth-promoting proto-oncogenes, let's say one of these things, it's no longer being suppressed by its normal signals, it's going to grow out of control. That's what's being demonstrated here. There's also something called haploinsufficiency, which is where the remaining tumor suppressor gene is insufficient. So you've got 2 genes, one from mom, one from dad. Maybe one of them, is good, one of them is bad, but the one on its own is not sufficient to really prevent the problem. Next, some more concepts being brought up here is the concept of a proto-oncogene, the concept of an oncogene and of a suppressor gene. So here we have, a normal cell. I guess it's a proto-oncogene, but it's not cancerous yet. Some kind of thing will happen to it. I guess it has accelerated heal for cell growth. I don't know what that means. So anyway, I'll go radiation or UV light, carcinogens, whatever, and that's going to cause this proto-oncogene to be damaged, taking out one of these guys, and it's going to be turned into an oncogene or a transformed cell. A constant growth signal, if proto-oncogene is damaged and altered to oncogene. So this proto-oncogene is now changed to an oncogene, and now it's going to undergo constant growth. And we also have tumor suppressor genes, which break for cell growth. So when these start to grow out of control, these tumor suppressor genes are going to say, hey, slow down. But if these tumor suppressor genes are inactivated or not working or mutated, then the cell cycle growth is going to go out of control. And it's unchecked. These are just going to massively divide. Apparently the suppressor genes like P53 or anti-oncogenes are always checking the cell cycle. And that is the end.